I haven't heard two classes of bug juice at this table. I haven't heard anybody really talking about the fluoroquinolones. And what about, here's a really old drug, polymyxins. Do they have a role here? Anybody want to step up on this one?
I'll take on fluoroquinolones.
Please.
Yeah, no role.
Okay, that's fine.
It's pretty easy.
Done.
The fluoroquinolones, I mean, in our hospital, less than 30% of our Pseudomonas are susceptible to fluoroquinolones. Okay. Beyond the fact that most people don't know how to dose the fluoroquinolones properly if they're going to use them, and of all the issues associated with fluoroquinolone safety, particularly for us, C. diff. So we've really trying to take fluoroquinolones out of our institution completely, so they're not really an option. As to colistin, polymyxin, all of those agents, this is an area where we're actually clearly getting into strong opinions because we don't have strong data, and that's the nature of medicine, is the stronger the opinion, the less strong the data. And I think all of us would agree that colistin is probably a laundry detergent masquerading as an antibiotic. Is it sometimes the only choice we have? Yes. Is it ever our first choice? In the US, no. In other parts of the world, yes, because they're dealing with higher prevalence concurrently of Pseudomonas, CRE, and Acinetobacter, and that's 50% of their infections, so they have to start with colistin. But nobody knows how to dose it properly, especially in critically ill patients with changing renal function. Do I use it sometimes? Yes. Do I use it for MDR Pseudomonas? Pretty much not, because I have other choices before I get there, to include not only different classes of antibiotics, but different dosing paradigms for the antibiotics we currently have, because one of the lessons that I've learned from my ID and pharmacy colleagues, and that's why I think it's important to realize this is a multidisciplinary group, is that pharmacokinetics matters. And just because I have an MIC in a test tube doesn't mean I can't figure out how to be smarter than the resistance by giving more of the drug over a longer period of time and optimizing these pharmacokinetic principles that we kind of forgot about from 20 years ago.
So I'll kind of build on both of those things, both with regards to first with the fluoroquinolones. I do think they have a role. First off, in our institution, our susceptibilities have come back a good bit because we restrict them. I think the bigger issue with the fluoroquinolones is that the MIC breakpoint might be wrong, and to your point, the way that we dose them is probably suboptimal in a lot of those patients. I'm not saying that I like them empirically, I'm not saying they're my go-to, but they're a potential oral step-down option in these patients. So I do think they have a role. With regards to the polymyxins, yeah, they have issues. Particularly, as Andy said, we have some other agents that we can use. And since you're talking about Pseudomonas, you're often talking about lung infections, and there's an emerging body of evidence that suggests that maybe those drugs don't work in the lung. And so they would be a suboptimal choice.
Okay.
Yeah, but just to add to that, and correct me if I'm wrong, Jason, but my experience has been, well, I'm sure he will as well, but over the last couple of decades, probably one of the most common combinations of empiric therapy has been piptazo and levofloxacin to cover gram-negatives. And, yes, you have to use, institution-specific antibiograms, but at our place and at most others that I can find, I can't find any evidence that there's any additive effect of combining those two drugs. And what you end up getting is the side effect of the levofloxacin, C. diff, et cetera, when in fact what that patient should get is an aminoglycoside.
So I agree wholeheartedly, and I think that brings us into the combination antibiogram piece of the story, because if you're going to choose a second drug, you want that second drug to be active against those that are resistant to the first drug. And when you have beta-lactam resistance, you do. You often have fluoroquinolone resistance as well, which makes aminoglycoside that better empiric drug. I completely agree with that. That said, I can tell you that we've long restricted fluoroquinolones at my institution. To Andy's point, we rarely use them, to be honest with you, and we have seen a rebounding in susceptibility to a degree, and I think they have a role, if used correctly, as step-down therapy to complete therapy from an oral standpoint.
And can we just put something on the table, because I hear this every day. Aminoglycosides, are they safe to use in patients with renal failure?
I think everybody would say that one dose of aminoglycoside while you are waiting for culture results to come back is fine. It's the extended duration and certainly the duration of exposure associated with the interaction with the current kidney injury and the fluid status of the patient all matter. I think none of us use aminoglycosides as our monotherapy definitively for Pseudomonas, particularly in the lung. And so in my institution, it's usually they're on something plus amikacin because that's our best aminoglycoside for 2 days. And if we know what the bug is, we drop to the one agent that's going to kill it. And if we haven't isolated a gram-negative, then it's gone.